The topic of today's talk is going to be pathophysiology of heart failure. And now this is quite the extensive topic, but I think I can break this down for you into an algorithm that allows you to see how any cardiac complication or cardiac problem can lead to heart failure through one of various mechanisms that we're going to describe. What we're going to do first is go over some very important variables and equations in cardiac physiology, and then show you how things go wrong with those equations in order to lead to heart failure. So, the first thing that we need to talk about is cardiac output. And cardiac output equals heart rate times stroke volume. Now, if you're lost already, that's okay. We're going to define these for you in really simple terms. So, heart rate is the amount of times that your heart beats per minute. And stroke volume is the amount of blood in milliliters that your heart pumps out per beat. And so when you do the math, these cancel out, and the units for cardiac output are milliliters per minute. And so cardiac output is how much blood your heart pumps out in milliliters per minute. Now, what we have to do is see what determines how fast your heart beats and how much blood your heart pumps out with each beat. Okay, so we're going to rewrite the equation up here. Cardiac output equals heart rate times stroke volume. And we're going to talk about what goes into each of these variables. Heart rate is pretty easy. In the right atrium of the heart, there's a specialized group of cells known as sinoatrial nodal cells. And so you have a node up here known as the sinoatrial node or the sinus node, and that determines how fast your heart's going to beat. Now there is autonomic input from the sympathetic system, which will increase the heart rate, and also from the parasympathetic system, which will decrease the heart rate. So these will modulate the sinoatrial node and allow for the heart to beat either faster or slower. Now, stroke volume is not quite as straightforward and is actually composed of three different things that determine how much blood you're going to pump out with each beat. And so the first one we're going to talk about is afterload. And I'm going to define these terms in a second. The second one is contractility. And the final one is known as preload, and you'll also see this as EDV, or end diastolic volume. So let's go over what each of these mean. And it's important to note that before we begin explaining these terms can apply to both the right and left side, but more commonly, when people use these terms, they're talking about the left side because this is the side that generates your arterial pressure. So afterload is the pressure that the left ventricle right here has to pump out against. And so that's this pressure here in the aorta that is basically opposing the blood coming from the left ventricle. So the pressure in this chamber is going to have to actually exceed that here in order to eject blood properly. Now, contractility is the actual vigor or force that this left ventricle contracts with. And this measurement, contractility, is independent of both the afterload and the preload. And so finally, the last variable is called preload. And preload is really just how much blood is coming in and filling the ventricle before it gets pumped out. And the reason you see EDV, which stands for end diastolic volume, and so at the end of diastole, when all the blood has come from the left atrium and into the left ventricle to fill it before it ejects, this is preload, or the volume at the end of diastole in the left ventricle. So I hope that those terms are clear, and now let's move on to how these three, afterload, contractility, and preload or end diastolic volume, contribute to stroke volume and overall to cardiac output. And so you'll see what I've done here is just list the three variables that we were talking about. And what I'm going to do here is make a little line separating preload from contractility and afterload. And we'll see why I do that in a second. But but it's because they cause different types of heart failure. So what happens when things go wrong? In the case of increased afterload, exactly what you think would happen. The stroke volume would go down. You're pumping against a higher pressure, you can't pump out as much. With contractility, if you have a decrease in the vigor or force of the heart muscle and it's pumping, you get a decrease in stroke volume. And finally, if you have a decrease in preload or end diastolic volume, you get a decrease in stroke volume. If you're putting less in, you get less out. And so these seem pretty simple, but really most, if not all, of the diseases of the heart can actually be traced back to modulating one of these factors. So we're going to talk about 3 diseases that can actually do these things, just to give you a little bit of a clinical context for how these diseases would affect afterload, contractility, and preload. So a disease of increased afterload would be something like chronic hypertension. And this chronic hypertension means that you have an extremely high pressure against which the heart has to contract. And like we said, that's going to lead to a decreased stroke volume. Now, a decrease in contractility could occur with something such as coronary artery disease or chronic ischemia. Ischemia just means lack of blood flow. And so if you have coronary artery disease, the heart is not getting as much oxygen and blood that it needs, and it can't contract as vigorously, and thus you get a decreased stroke volume. Finally, a disease in which you would have a decreased preload is a little less common than the other 2 that we mentioned, but something like constrictive pericarditis. And so the pericardium is the sac that surrounds the heart, and in cases like infection or something like a heart attack, you can get chronic inflammation of that sac that surrounds the heart, and what happens is it becomes very fibrotic and scarred and doesn't allow the heart to expand. And so if the heart can't expand to take in the volume that fills it, you get a decreased preload or a decreased end diastolic volume and a decreased stroke volume. So now you can see how some common conditions that we see in the hospital every day can actually lead to heart failure. And so the last term that I want to introduce to you is something called ejection fraction. And the ejection fraction is no more than the stroke volume over the end diastolic volume. And in layman's terms, that just means how much blood are you pumping out in relation to how much you got in. And so a normal ejection fraction is something like 55%. An ejection fraction is also commonly used in the clinic to evaluate heart function. And the reason I introduce this is because we can look and see what happens to the ejection fraction when all 3 of these variables are changed. And so if the stroke volume decreases in both increased afterload or decreased contractility, the preload or end diastolic volume is either going to not change or will actually increase, because since you're not pumping as much blood out with each beat because you have a decreased stroke volume, some of that blood is retained and this value may actually go up. But what the point is that ejection fraction, because stroke volume is going down and end diastolic volume is going up, ejection fraction is reduced. And another name for reduced ejection fraction heart failure is systolic heart failure. And both a decrease in contractility and or an increase in afterload can cause systolic heart failure. Now, if we go over to the preload side, the ejection fraction here will be different. And so you have a decreased stroke volume, but you also have a decreased preload or end diastolic volume. And so if both of those decrease the same amount, you actually have no change in ejection fraction. And this is called preserved ejection fraction heart failure, or diastolic heart failure. So I hope that by watching this, even though there are a lot of variables and a lot of equations, that I can simplify this for you so that you can see a condition such as hypertension, which is extremely prevalent, or something like coronary artery disease, and see how that affects different variables that determine the cardiac output.